So, on behalf of Screen and Jay and the Rutgers Cancer Institute, hello and welcome to Community Cares and Project Echo. Thank you for joining us for today's session, and we hope that the information that is shared today will help you serve your community better. And I have a few announcements before we begin the presentation. I also want to let you all know Sarah, who usually runs these, she is graduating today with her MPH, so she was not able to join us, but a little congrats to her from all of us. So, a little housekeeping. So, the information contained in this presentation is not a substitute for medical consultation. A physician should always be consulted for any health problem or medical condition. And today we are going to do our as usual, Project Echo series overview. We'll introduce our amazing speakers. We'll have the presentation, the case study, and then we'll do our Q&A forum and then some post housekeeping. So the Rutgers Cancer Institute became a Project Echo hub in 2021. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The ECHO model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. And this is done by using technology to leverage scarce resources, sharing best practices to reduce disparities, applying case-based learning to master complexity, and evaluating and monitoring outcomes. And for more information on Project Echo, you can visit the echo.unm.edu website. So now to our speakers. So Dr. Louise Legresti is the Chief Cancer Survivorship at Rutgers Cancer Institute and RWJ Barnabas Health. So Dr. Legresti has been a dedicated medical oncologist for over 25 years. Her journey in medicine began in childhood. She is the first in her family to graduate from college and became a doctor. She's always viewed medicine as a calling, and that passion has guided her throughout her career. She earned her medical degree from Upstate Medical Center in Syracuse and completed her internal medicine residency at New York Hospital Cornell Weill Medical Center. She went on to serve as chief medical resident at Memorial Sloan Kettering Cancer Center, where she also completed her fellowship in hematology and oncology. Dr. Legresti has provided exceptional care both in private practice in Bergen County and in academic medicine at MSK in Basking Ridge and Bergen. Her approach has always been patient-centered, grounded in compassion, respect, and clinical excellence. She has also contributed to advancing cancer care through participation in clinical trials. And as Chief of Cancer Survivorship, Dr. Legresti is focused on improving the care and experience of cancer survivors throughout their journey, and this through innovative clinical care, survivorship research, and education. Meg McQuarrie is the co-founder and executive director of the Elixir Fund, an organization dedicated to improving the comfort and care of cancer survivors and their caregivers. She is a certified lay navigator and helps survivors and caregivers nationwide find and access services in their local areas. Meg oversees the Elixir Fund Registry, a free online service that allows anyone facing a medical diagnosis create an easy to share list of their support needs. She has firsthand experience with the benefits of complementary therapies for those impacted by cancer and is always looking for ways to make this more accessible to survivors and caregivers. She leads an online guided meditation program, and we've run that program. It's a fantastic program. And co-facilitates a twice monthly Jin Shin Jutsu self-help program for cancer survivors. Meg is also the chair of the Survivorship Work Group for the New Jersey State Cancer Coalition. So now I will pass it on to Dr. Legresti so that she can begin her presentation.
Okay. So I wanted to talk about survivorship care because this has been sort of an ignored, underserved area of medicine in oncology. Pa- We're, can I control the slides or no, Evelyn? So next slide. So let's do a pretest and see how many cancer survivors are there in the United States presently. So 7 million, 13 million, or 18 million. And then which cancer type has the most survivors in the United States? Lymphoma, prostate cancer, or breast cancer? And what is the leading cause of death in long-term survivors of Hodgkin lymphoma? Cardiac disease, Hodgkin disease, or other malignancies?
So
And these
Dr.
are some
LeGrand,
of the things, yeah,
oh, I'm so sorry. What were you going to say?
these are some of the things that we'll cover during our presentation.
And we'll give everyone about a minute to
Yeah,
answer. Just okay. And we'll share the answers at the end of the presentation.
yeah. Next slide. So just to show you how important survivorship care is, there is a growing number of cancer survivors in the United States and throughout the world. And it's estimated that in 2029, there'll be 22 million cancer survivors, and by 2040, there'll be 29 million cancer survivors in the United States. As of as of right now, there are 18 million cancer survivors, which represents a little over 5% of the population. Next slide. So, estimated number of cancer survivors in the United States by cancer site, of course, breast is usually the number one because it's just a very common disease and it's detected early. So there are many cancer survivors from breast cancer, but you see prostate cancer is not far behind. And then cancer survivors mean people who have been sort of cured of their cancer, but also people living with cancer. Anyone who has had cancer and is living is a cancer survivor. Colorectal cancer, GYN cancers, hematologic malignancies, melanoma, you see, is very common with a high survivorship. So there are a number of cancer survivors in the United States of all different kinds of cancer, breast being number one. Next slide. So the NCI has recognized the importance of cancer survivorship, and they have issued national for survivorship care in the United States. And they really recommend that the health system have an organization where cancer survivors are provided access to a survivorship program, whether it be through referral or telehealth or on-site, but they should have access to a cancer survivorship program, and it may not be at their institution, it may be by referral. Patients should be able to access cancer survivorship care at multiple points in their care. So it can be at the beginning of their cancer journey, it can be after they've completed curative intent therapy, or it can be for people living with cancer that have cancer survivorship needs. The NCI also recommends that, there be a policy where the stakeholders for survivorship care establish a program that addresses the needs of cancer survivors and is guided by survivorship guidelines, which are provided by the American Society of Oncology as well as the NCCN, and for childhood cancer from the Children's Oncology Group. The NCI also recommends that the health system have a way of evaluating and assessing the benefit of their program using patient reported outcomes, evaluating quality of life, functional capacity, but also, outcomes in terms of survival, picking up new cancers, things like that. So, what goes into a survivorship program is quite a lot. Next slide. So there are four major areas of focus in cancer survivorship, and this includes, you know, evaluating and identifying recurrence and new cancers. So recurrence of the cancer that the patient had, but also development of new cancers that they may be at risk for. Long-term and late effects of treatment, so including cardiac issues, neuropathy, fatigue, debilitation, cognitive changes, but also addressing modifiable health behaviors. This is actually a very important part of cancer survivorship, and it overlaps with the care provided by primary care providers. So patients who have received certain kinds of treatment are at risk for heart issues in the future. And those patients really should be counseled on controlling their weight, engaging in physical activity, controlling their cholesterol, blood pressure, all of those kinds of things that really can have a very vast impact on their long-term survival. In addition to this, in cancer survivorship, we do try to coordinate care with the primary care provider. Most patients will leave cancer survivorship at some point in time, depending on their disease and the treatment they've received. And then the baton will be passed to the primary care provider. It is certainly beneficial if the primary care provider has the, information of the treatments the patients received, what they're at risk for, what the follow-up should be. You can't, I don't think it can be expected of primary care providers to keep up with all of the, recommendations and, standards for every field, right? They're taking care of patients with heart disease and pulmonary disease and cancer. So, it's good for us to give them a guide as to how to follow patients in the future and what patients are at risk for. And that's often done with a survivorship care plan or treatment summary that we do try to give the patients and their primary care providers at the end of their curative intent treatment. And it includes a list of their providers. It includes the stage of their disease, what treatments they have had, any genetic testing that they've had, and then a sort of a guide map as to what they should be doing in the future and the follow-up that we would recommend. Next slide. So coordinate cancer survivorship is very, multifaceted, and you can see how many things go into it. So there's the primary care provider who's involved, certainly the patients at the center of it, and the oncologist, but there are many other specialists, care coordinators, navigators, who are all involved in the care of the patient. And, it's important to follow metrics. We have a system of following metrics in our clinic, and we're constantly modifying it to try to address the needs of all of the patients and to that lead to the best outcomes. In terms of visits with patients. We do both in-person visits, but we also do virtual visits because a lot of it is really coordination of care and, educating patients as to what they may be at risk for in the future based on the treatment that they've had or the disease that they've had. So that can be done in a brisk telehealth model as well. And, we do use that in our clinic. Next slide. So the mission of cancer survivorship at the Rutgers Cancer Institute is to foster the implementation of evidence-based practices, improve quality of life, and optimize outcomes for cancer survivors in New Jersey. So that I always see that as our mission, as our primary mission. Next slide. So let's look at one of my patients that I've seen in my clinic in the last couple of months. So LM is a 35-year-old female with a history of a stage 2A classic Hodgkin lymphoma in 2016. So she was young, in her 20s when she had this, and she was treated with 6 cycles of ABVD followed by mantle radiation therapy. So ABVD is chemotherapy, and the A stands for adriamycin, which gives a risk of heart disease in the future. B is bleomycin, which gives a risk of pulmonary disease. V is vinblastine, which really basically lowers the blood counts, and DTIC also lowers the blood counts. But the main issue is the mantle radiation therapy. So she received radiation therapy to the center of the chest, into the lower neck. And she received it at a very young age, so under the age of 30. So this is the crux of, what is important in this particular patient. Now, she had Hodgkin lymphoma in 2016 and it's 2025. She's likely cured from Hodgkin lymphoma. So why does she need survivorship care? Well, let's look. Next slide. Oops, what happened to my, there it is. So if you look at the risks of death from major diseases in patients with Hodgkin lymphoma, in the green line, you'll see that the risk of death is from Hodgkin lymphoma, but it's really in the first 5 years, right? So in the first 5 years, you recur or you don't, and then the graph plateaus. So after 5 years, it's unlikely for Hodgkin lymphoma to kill you because in general, you don't recur after that point in time. But look at the brownish line, the big sloping line. That's other diseases. And look at all the other diseases that can occur and lead to mortality for patients. And if you look at the orange line, the highest risk is other solid tumors. So other cancers is a high risk for patients who have had Hodgkin lymphoma, whether it be from having Hodgkin lymphoma alone, but more commonly from the treatment that they've received. And if you see second in mortality is cardiovascular disease. So these patients do have a higher risk of heart disease from the treatment that they've had. And if you look, you'd say, well, it's 45 years later, patients are old by that point in time, so of course they die from other diseases. But if you look at studies looking at patients and their siblings, so that kind of takes out the genetic component of it, right? Because you're looking at patients who have had Hodgkin and their siblings. Hodgkin lymphoma patients have, a higher risk of mortality from all of these diseases than their siblings. So, if you think of this patient, especially with Hodgkin's disease, she had Hodgkin's disease in her 20s. So 40 years later, she'll be in her 60s. That's still young, right? But she has a much higher risk of mortality from other diseases because of having Hodgkin's and her treatment. Next slide. So there are recommendations as to how to follow patients who have had Hodgkin lymphoma. And this is a very big part of what we do in the survivorship clinic. So for this patient who has had mantle radiation therapy, what's in the field are the breasts, and she's a female. So it's recommended these patients can have over a 20% chance of developing breast cancer in their lifetime. And the risk starts at about 7 to 8 years after the radiation, and especially if they received radiation prior to the age of 30, they have a much higher risk of breast cancer. So this patient at the age of 35, who had had radiation 9 years before, is certainly a candidate for breast cancer screening. So I ordered a mammogram for her. you'd say, well, maybe a mammogram is not that good in patients that are young because their breasts are dense. It's still better than nothing. And in addition to that, patients are eligible for breast MRI for screening, which is more sensitive in younger patients. So for this patient, I did order a mammogram and an MRI to start her annual screening for breast cancer because she does have a dramatically higher risk because of the mantle radiation therapy that she's had. Because of this, we don't use mantle radiation so much anymore. So it's really it's a very, uncommon. We would rather give more chemotherapy and less radiation because of these long-term risks. Now, the other thing I can consider for this patient is to consider a discussion of chemoprevention. So giving her a hormonal therapy that reduces her risk of developing breast cancer if she is so inclined to take medication for that. But that's also a discussion I had with her for regarding her breast cancer risk. So these patients are all for lung cancer, especially if they've had a smoking history. So we are very, very emphatic that these patients should not smoke because it does dramatically increase their risk of smoking. In general, we don't do screening unless they have a smoking history. Um, we do recommend an annual complete skin exam for these patients. Remember, in the radiation field, is a higher risk of skin cancer. And we are very emphatic that these patients should use sunscreen, wear, clothing that covers them in the sun so that they reduce their risk of developing skin cancer. Also, patients are at a higher risk for colon cancer, especially patients who have radiation below the diaphragm. So in the abdomen, that we do recommend that patients have colorectal screening 10 years earlier than the general population. So a patient that's 40 years old that's had treatment for Hodgkin's disease has a risk of a 50-year-old of developing colon cancer. So we do recommend screening for those patients. So you can see that there's a lot of cancer screening that's necessary for these patients. And if, the patients are not seen in a clinic where this is well known, they may slip through the cracks and not get the proper screening. Next slide. Now, in terms of cardiovascular health, these patients certainly are at a higher risk because of the chemotherapy that they've received, as well as radiation to the heart. The heart is in the field as well. But even just having had the chemotherapy, they're at risk for heart disease. So the patients in general usually get an echo prior to their chemotherapy. So we know they start out with normal heart function, but it's not unreasonable to have patients get an echocardiogram on, maybe an every few year basis just to make sure that their heart function is good. And there was a recent study looking at patients with breast cancer who also received this kind of chemotherapy. And at 20 years, they had about a 20% chance of developing some kind of heart dysfunction after treatment. So the risk doesn't go away when the treatment is done. And certainly it's important to be very vigilant if patients develop symptoms and to, evaluate those promptly. In addition to this, it's very important to minimize traditional risk factors. So avoid smoking, have your body mass index in the normal range. If you have high cholesterol, to treat it. If you have hypertension, to treat it, and to maintain good physical activity. Patients also who receive radiation, the lower neck is included, and we should be listening for carotid disease, where patients can be at a higher risk of strokes. So listening for bruits in their neck to make at an earlier age than would normally be recommended. These patients also can have lung issues. I told you that bleomycin that they receive definitely can cause long-term lung damage, and smoking amplifies that. So again, another reason for patients to avoid smoking, but radiation also amplifies the risk of lung damage with the bleomycin therapy. So again, being vigilant if patients have any respiratory symptoms to evaluate them promptly and send them to a pulmonologist. Next slide. These patients are also at risk for endocrine problems. So hypothyroidism is very, very common in patients who receive mantle radiation therapy because the thyroid is in the field, and they should have thyroid function tests through blood work annually. And that's really lifelong. In general, they develop hypothyroidism in the first 5 years, but it can happen later. These patients are also at a little higher risk of diabetes, and they should have a hemoglobin A1C and a fasting glucose annually as well. And certainly this is at an earlier age than patients would normally get these things. And then certainly infertility for patients, for young patients who have received chemotherapy. This patient has already had 2 children, so not an issue with ABVD, low risk of infertility. But, in patients who have had transplants, high dose chemotherapy, higher risk of that. And we refer patients to a reproductive endocrinologist for that. These patients do have a much higher risk of depression and anxiety, and it's lifelong. It's not just during the treatment. They also can have cognitive issues from the chemotherapy. There's something called chemo brain, which is actually a real entity that's not well described at this point. But if we do cognitive testing prior to and after treatment, there are subtle differences in cognition. In general, it does improve, but it's important to certainly validate, what the patient is feeling, and we can send patients for cognitive therapy, which can be very, very helpful. And we have to be on the alert for depression and anxiety, which can sneak up on these patients after treatment. Next slide. So my recommendations for LM were that she receive a mammogram and have a breast MRI and consider chemo prevention. She's due for an annual dermatology visit for skin screening and colon cancer screening. She's eligible for that as well. The age is 45 now for screening, and she's 35, so 10 years earlier. Cardiac, I recommended that she, have a normal, healthy weight, exercise regularly, lower her cholesterol, control her blood pressure, avoid smoking. For pulmonary, again, avoid smoking. And I drew her thyroid function test and hemoglobin A1C, and screened her for anxiety and depression. So you see, it's very complex, all of the things just based on the treatment. 9 years ago, this patient's probably cured of her cancer, but she has all these other things to consider. And these are the things that we address in a survivorship clinic. Next slide. I don't know what happened to the post-test, Evelyn.
Oh, the post test will go after Meg's portion.
Okay.
So
Okay.
that was your last slide?
That
The
was
this
my
slide?
last slide.
Okay, great. And now we'll move on to Meg's portion. Thank you so much, Dr. Legresti.
Thank you, Evelyn. So I'm going to summarize my presentation by saying everything that Dr. Ligresti just mentioned, there's a hold for that, and you'll understand when I finish. So Jinshin Jitsu is the art of getting to know and help myself. I just want to step back for a second and say that my experience with cancer began when my brother was diagnosed with cancer. And at the time, he and I lived in the same town. So I walked through the day to day with him. And he and I, from both perspectives, found complementary therapies, meditation for him, yoga for me, very helpful in dealing with the stress associated with treatment and a lot of the other side effects. So I am passionate about complementary therapies, but it's not always easy when you're in the thick of treatment and just trying to get through the day to day. If you're not already a regular practitioner, it's kind of hard to pick up those complementary therapies. So about 10 years ago, I was introduced to Jinshin Jitsu, which sounds very active. Next slide. Jinshin Jitsu is actually an ancient Japanese art. You can think of it similar to acupressure, acupuncture, Reiki. It's the idea that there's energy in the body. We think of this as chi or life force. And when that energy becomes stuck, it can lead to discomfort, pain. It can lead to illness. It can lead to worry, anxiety, so different emotions as well. And the premise with Jinshin Jitsu is that your hands are the jumper cables that can help unstick this energy and keep your life battery running at its best and most harmonious. Next slide, Evelyn. So Jinshin Jitsu, just briefly, it is an art, and it's referred to as an art rather than well, it's a modality as well, but Jinshin Jitsu dates back pre-Buddha, and it had largely been passed down through word of mouth and demonstration. And in the early 1900s, a Japanese man, Jiro Murai, was suffering from some illness, and he used Jinshin Jitsu to help himself, and then set about trying to study Jinshin and bring it back into the mainstream culture. In the 1940s, Mary Burmeister, a Japanese American, was visiting Japan, met Jiro Murai. He offered to share his gift and have her bring it back to the United States, which she did. So, and actually was based in Arizona. I know somebody on here today is in Arizona. So all of the teachings in the United States kind of descend from Mary Burmeister. And so you'll often hear her quoted. So as one of her quotes is here, the art of living is simple, and we complicate it in our efforts to try and live, or is it just to exist? Next slide. So while I talk, I thought we could all, I want this to be interactive. So I invite you to do the Jinshin hug, which is just crossing your arms and putting your hands under your arms with your thumbs on the outside. Relax your shoulders is key to this. If you want, you can drop your head and just breathe. You don't have to squeeze, you don't have to hold this tightly. If it's hard to cross both arms, you can do just one at a time. And just breathe. You can continue to hold this as I talk. So the Jinshin Jitsu hug is a very basic hold. And again, the key is to have your shoulders dropped, because you really are trying to help energy move in your body. And if your shoulders are tight, that's going to prevent that movement. Next slide, Evelyn. I'll come back to the hug and its benefits, but I wanted to point out that Jinshin Jitsu has been studied in a clinical setting. The Markey Cancer Center had a robust program for a number of years. The Academy of Integrative Health and Medicine in San Diego, Morristown Medical Center. So studies have been done about how Jinshin Jitsu helps with pain, stress, and nausea associated with treatment. Morristown Medical Center has actually had Jinshin Jitsu as part of their integrative therapy since 1993. If you are a patient, the focus was cardiac and oncology, but if you are a patient at Morristown Medical Center, you can ask for integrative therapy. You can ask for an order to have integrative therapy, send a practitioner to you, and they have a basic flow that they do for patients. What you're doing now, holding under your armpits, there's lymph nodes in that area. So this is great for helping to detox. So this is a great thing. The flow that they do in Morristown helps, particularly post-surgery, to help move the anesthesia. Jinshin Jitsu has also been shown to be helpful for promoting the healing of mouth sores and the prevention of future mouth sores. And that was a study done in Oregon. Next slide. So now with the hug, the benefits of the hug, this helps to calm your mind. So if you're feeling a little out of sorts, you can just give yourself a hug. It helps refocusing your thoughts. It boosts your immune system. This is good for breast projects. Jinshin Jitsu is an art, and it's an art of getting to know yourself or each individual's. So rather than talking about issues, Jinshin Jitsu refers to projects because projects are more fun than issues. So these are things you may want to work on over time. So Jinshin doesn't talk, you'll see reference to projects. This helps with cardiac projects as well, fatigue, um, facial paralysis, neck and shoulder, respiratory, thyroid projects, and much more. Next slide. You can continue holding the hug if you want or let your hands go. That's up to you. In Jinshin Jitsu, there are 26 safety energy locks, so mirror images. So there's 26 on each side of the body. And when you're doing Jinshin, you can do self-help and hold these safety energy locks, or you can actually hold a series of them, which strung together is a flow. Jinshin Jitsu can be done for yourself. It can also be done on other people. So if you visit a Jinshin Jitsu practitioner, you just lie on a table, you're fully clothed, you lie on your back, and the practitioner will hold different points on the body. But again, this is something that you can do for yourself. And as Mary Burmeister liked to say, you know, the beauty is your hands are with you. So you can do this anywhere, anytime. What I wanted to point out is that each of those safety energy locks has a corresponding finger. So if nothing else, you can always hold your fingers. Next slide. So each finger has a corresponding attitude and organ function energy. It's not necessarily a corresponding organ, and that's because of how the flows work and where they move in your body. But simply holding a finger can help 14,400 body function energy. So it's pretty powerful. Next slide. This is just a little bit more detail on the organ functions that's already on the hand and the different attitudes. But while I talk about them, I thought, again, we would be interactive. So next slide for me. Thanks, Emily. What we're going to do is I'm going to encourage you to just hold each finger. I'll explain the benefits of that finger. You don't have to squeeze. Just wrap your fingers one hand around the thumb. We'll start with the thumb. And that's why I have the image here. And then we'll end with the hands together, prayer position or palms together, whatever is comfortable. So go ahead and hold your thumb. And Evelyn, if you don't mind going back one slide, I'll walk through them. Thank you for that. So just, again, what you want to do is just hold your thumb gently. You can rest your hands in your lap. You want to make sure that you're comfortable. You can't hurt yourself with Jinshin Jitsu, but if anything does make you uncomfortable, then don't continue with it. So you just hold your thumb and breathe. The attitude with your thumb is worry or anxiety. So holding your thumb can help with anxiousness. We recommend this for when people that scan anxiety that comes with post-treatment or treatment. And the organ function that it helps with is the stomach and the spleen. So the physical symptoms associated with that could be stomach aches, headaches, but it also helps with skin problems and nervousness. So if you're having a headache, you can hold your thumb, stomach ache. And just breathe. Moving to your index finger. Your index finger corresponds to fear, mental confusion, and frustration. The physical symptoms include digestive problems and muscle problems, such as a backache. The organ functions are the kidney and the bladder. So I use the index finger as a gateway to hook people to Jin Shin Jitsu because anyone drinks coffee, or if you're one of those people who has your bazillion ounces of water a day and you feel that rush that you have to get to the bathroom, remember your index finger. Holding your index finger helps take that edge off, helps take that panic. Just breathe. And this, if nothing else, that's your takeaway from today. And then when it works for you, you can come back and find me. Yeah. Remember your index finger, Emily. If you are in such a place that you can't just simply hold your index finger, you can also put your each thumb over the pad of your index finger nail and hit two at once. If you're out for a walk, sometimes a little easier to do the thumbs over the index finger rather than over the fingernail rather than holding your index. Moving to your middle finger. Your middle finger corresponds to the attitude of anger. This is the easiest one to remember the attitudes. Middle finger in anger, as they like to say in Jin Jin, grip it, don't flip it when you're feeling angry. So irritable, indecisiveness, your middle finger. It also corresponds, interestingly, to vision problems. So if you've ever said or thought, I was so angry I couldn't see straight, that helps you to remember as well. And I just said vision problems. I should have said projects. This helps with fatigue, circulation, and the organ function energies are your liver and your gallbladder. Moving to your ring finger. Your ring finger corresponds to grief, sadness, negativity. This also corresponds to the lung and large intestine organ functions. So physical symptoms that it helps with: digestive issues, breathing, or serious skin conditions. So again, because this is the lungs, for example, if you're exerting yourself and having trouble breathing, you can hold your ring finger, or once again, put both thumbs over the ring fingernail. I have someone who uses this when she goes hiking. Also, your, as we said, large intestine, so also good for other digestive issues. moving to your little finger. The attitude here is trying to or pretense. So this corresponds if we're overdoing it, if we're efforting. It is your heart and your small intestine organ function. So this is helpful for cardiac, physical symptoms. Physical symptoms include bone or nerve problems. This is also very helpful for a sore throat. You can finish by putting your palms together, however is comfortable. The center of the palm emotion is imbalanced. When it's imbalanced, it's despondency. And this is your umbilicus or diaphragm organ function. So any symptoms that may occur in that area. And when this area is in balance, we feel a profound sense of peace. So again, this corresponds to holding the hands in prayer position or holding the hands together in that idea of peace. A lot of this you will find comes intuitively to you that you hold locations already that correspond to where the energy might be stuck. So we already have an intuition about this. Working through the fingers, we just did one hand, but a nice meditation, a nice flow is to hold all 10 fingers and end with your hands in prayer position. You hold them as long as you want to hold them, as little or as long. You may feel a pulsing sensation after you've been holding a finger for a while. That's an indication that it's unstuck. You may or may not, or as you work with this, you may feel that more readily. The benefit is you can't hurt yourself doing this. Your hands are with you. And even if you don't know what each finger corresponds to, just holding a finger, sometimes if you don't think about it, you'll just be drawn to holding a finger. And just holding your finger, working through all 10 fingers is fantastic. As I said, there are other flows, there are other locations on the body. You can go much deeper into the study of Jinshin, but all roads kind of lead back to your fingers. So if you know nothing else, that is beneficial to you. Those of us who have worked with Jinshin can give you all sorts of firsthand experience and stories and personal benefits. As I said, Dr. Ligresti mentioned a number of follow-up issues that there might be post-treatment. Jinshin Jitsu is a wonderful complement. I will not say you need medicine as well. It's a wonderful complement to help boost all the other things that you are doing. At the very least, you sit and you breathe, which is a benefit. The other thing about Jinshin Jitsu is it's lovely if you can sit quietly and do it, but you don't have to. So if you're sitting watching TV, if you're trying to fall asleep, it's great. And there's holds for that as well. If you have fatigue, if you have trouble falling asleep, it's really a wonderful modality. So the next slide, Evelyn, I think it's just after the hand holds is just that we have the next one. We offer, as Evelyn mentioned, Jin Shin Jitsu for cancer survivors and caregivers. We meet twice a month. We just walk through different holds and we take suggestions of what it is that people are working on. We've done nausea, neuropathy, fatigue, and more. And then I lead a weekly guided meditation as well. And I know you wanted time for questions, Evelyn, so that's all for me.
This was wonderful. Meg, you kind of answered the question I had because I was going to ask you about does it matter which hand, like if your handedness, but it doesn't seem.
No, it's really great. In the way with Jinshin work, that's often opposite sides of the body. So your left side helps the right side, vice versa. Top helps bottom. So it's, but really, you're going to be drawn. No, it doesn't matter which hand. You can do both sides. And in the case of, so it's also your intention. So that is a big part of it. So Jinshin can be done, on people, even if you're missing a limb, or a lot of it is the intention as well.
Okay. I don't see any questions in the chat, but I do have a question for Dr. Legresti. Oh, someone does.
Okay.
Does the way you hold the fingers matter? So I'm guessing this one's for Meg.
No, it does not. You can hold with the thumb on the back. You can hold in certain, for us as practitioners, there'll be certain directionality, but no, it really doesn't. For you holding, it does not. So whatever feels comfortable.
Um, my question for Dr. Legresti is, in conversations with cancer survivors, I've noticed that sometimes there's this anxiety where they've gone through treatment, they've finished their treatment, but they feel that connection with their oncologist, and they want to make that they're thinking of that oncologist as their primary care, but they really have to I think go back to primary care, or what happens in those situations?
Yeah, it's changed over the years. Years ago, we used to serve as the primary care for patients, certainly during treatment and after treatment. But, that's no longer true. We do encourage patients, even during treatment, to have a relationship with their primary care providers. So that's changed over the years because these patients have other complex medical problems. These patients could have diabetes or, high blood pressure or heart problems. We're by no means competent to care for those things. So we do encourage patients to have a relationship with their primary care provider. And we try to have some boundaries as to what they call us for and what they call their primary care provider for. In terms of, for survivorship, we try to couch the transition, and it can be a transition or it can be an addition. So for some patients, in some places they will transition over to survivorship after a few years. So when I was at Memorial, after 2 to 3 years for breast cancer, you would transition to a primary care, to a survivorship provider, and that was your new oncology team. But other places, it'll be complementary. So we might see patients as a consultative visit after their treatment is done, give them a survivorship care plan, a treatment summary, and then maybe we'll see them once a year and they'll continue to follow with their primary oncologist. So there's different models of survivorship care, but the primary care provider is integral no matter which model you use. In terms, we do try to tell patients that any kind of transition to survivorship is a promotion, right? I mean, that's what it's meant to be, right? Because the survivorship patient, the oncologists don't have the bandwidth to take care of all their survivors. Thank God, right? I mean, that's such a wonderful thing to be buried under survivors. So, eventually we do try to tell them at the outset of treatment that they will advance on to their primary care provider, and that'll be the person that they see from going forward.
And we have another question for you, Dr. Legresti. Do you have recommendations for how information is shared and stored across multiple healthcare systems as patients work with their PCP?
Yeah, so I mean, for us, the survivorship care plan or treatment summary, it's embedded in Epic. We've devised different treatment summaries that are disease specific, and that's been actually really, really helpful. And we've done that as a network, the RWJ network. We really have tried to devise. We have one for transplant, one for breast cancer, one for prostate cancer, one for lymphoma. We have all different ones, uterine cancer. And we try to send that to the primary care provider. So it's a roadmap as to how patients should be followed. I think that Epic and certainly, the technology has helped us tremendously in that we're not duplicating resources. So if patients have had blood work with their primary care provider, that's usually the same blood work I would draw. So I don't have to duplicate it. I don't have to have my secretary call and find when the blood work was done. I can see it in the medical record, which is so terrific. So that's been a real help as we've advanced to, share a network because more and more networks are sharing, their information. That's been wonderful.
Thank you for that. I'm going to launch the post test real quick since we have about a minute. And if anyone has other questions while we're doing the poll, feel free to unmute yourself and ask. And then also in the link in the chat, I've posted our eval link. Please let us know what you think. When you guys fill out these evals, you're giving us great feedback and it helps us in turn as well. For access to today's recording and past sessions, please make sure to join into Mighty Networks. And then also I have the link here for Seed. Our next session is going to be on June 24th. And it will be about sexual and reproductive health. So I'm looking forward to seeing everyone there. And I am going to go ahead and end the poll. Dr. Legrassi, do you want to go ahead and give us the
Answers?
answers?
Yep. So cancer survivors in the United States, there are 18 million presently. So most people got that correct. And which organs, which cancer type? It was absolutely breast cancer. It's just more common. Nobody guessed prostate cancer, which was only a little bit behind, right? And then the leading cause of more, issues for patients with Hodgkin's lymphoma is other malignancies. You saw that line. That was the highest risk. A lot of people think it's cardiac disease, but it actually is second cancers. So
Thank
I
you
hope you
so
learned something
much.
from this.
I learned a lot. I myself learned a lot regarding the heart and cardiac. I wasn't aware how many cardiac issues can arise from treatment. Just going through. Okay, everyone. Well, thank you so much. We'll see you 10 a.m. Eastern Daylight Time on the 24th. Quick update. Also, we're having a special CNS, brain, and spine health echo next Wednesday at 10 a.m. You should have all received some kind of newsletter um, uh, with the flyer information and how to register. So hopefully we'll see you all there as well. Have a great day, everyone. Thank you.
Thank you so much.